Hello, and welcome to the webinar. This is Dr. David Nace, Chief Medical Officer at Innovaccer, and we are thrilled to welcome all of you to this wonderful end-of-the-year recap on what has been not so wonderful of a year and the lessons that we learned in healthcare. So we're so excited about what the future may lie and the hope that's been instilled by some of the advances we've seen in vaccine and other arenas, and yet we're shaping the year thinking about our experience with COVID over the past year. So it's a great time to recap and think about lessons learned, what the future is. So we've got two wonderful panelists joining me. Dr. David Nash, founding Dean Emeritus at Jefferson College of Population Health, and has been a good friend and colleague over the years. David, welcome.
Thank you. Great to be here.
Great to have you. And then also very pleased to welcome Julie Fowler-Smith, Vice President of Information Technology, Clinical Applications, Enterprise Reporting and Analytics from Banner Health. Julie, it's great to have you join.
Thank you. It's good to be here.
So with these two wonderful perspectives, Jefferson Health System, Banner Health, let's get started and talk about the topic at hand. So let's start off with you, Julie. You know, you had been at Banner for a little bit and dealt with the pandemic when it first started in March. What was your experience in terms of how you had to start dealing with this crisis?
Yeah, I think one of the experiences, and I think a kind of a point of contention was, where is the data? And how do we provide data and reporting to our operational resources? So we sort of started out, I think we all did, with not knowing much about COVID and not knowing much about all of the different data that corresponds with COVID. And so the first kind of 2 or 3 months, we spent a lot of time combing through disparate data systems within Banner, looking for the appropriate data to be able to have actionable data for our executive and operations staff.
Yeah, it was a very complicated year with all the shortages and having to think about new ways to connect with patients. David, what was your experience at Jefferson?
Well, I wish I could take personal credit for it, David Nace, but I'm on the other side of that mountain. So our leaders like Dr. Bruce Meyer, our chief medical officer, senior vice president, basically our top doctor, Dr. John Gleason, Dr. Judd Hollander. I mean, we have an amazing leadership team. So because we also had a unique relationship with a medical school in Rome, Italy, back in the beginning of 2020, we had, for better or for worse, very direct warnings from a clinical perspective what was headed our way. That enabled us, I think, to get a very nice running head start in January of 2020, before the first surge hit Philadelphia in March and April. This time around, I think the folks at the bedside, including people like my own daughter, are much more accustomed, despite the exhaustion. I think the frenzied aspect is probably not there, and there's resignation of what we have to tackle. So psychologically, people are exhausted, but more confident, certainly than we were back in April and May of 20. So the good news is, as you alluded to, there's light at the end of this terrible tunnel.
And Julie, you know, as COVID began back in March, and when you were at Banner, you know, how did you start thinking about how to, as a system, deal with patients in a different way? Because I know a lot of folks have started to not just think about data, but also think about new tools and techniques in order to engage patients.
Right. I think one of the realities was we just simply didn't have enough physicians and medical staff to make certain that we had oversight and insight into all that was going on in each of our hospitals. So we began to look at our partners, especially our telemedicine partners and our partner Innovaccer here, to say, how can we provide a broad view into the activities here at Banner so that everybody can go one place every morning and throughout the day to see how Banner is doing as a whole. Obviously, us operating in 6 states, we have almost 30 hospital locations and 400 plus clinics. So we needed a central location for the aggregation of data and the visualization of that data across the Banner platform. So we turned to Innovaccer and 3 of our telehealth vendors to begin that journey.
Now, that journey has evolved to the current situation, which we've seen a change in. David, we've actually seen this surge. How are we thinking about that as a community, as a health system?
Yeah, so to pick up on something, excuse me, that Julie said, like a lot of big places, we have our dashboard, which is updated multiple times per day. I had a briefing this morning at 8 o'clock from our pharmacy leadership. They have sort of a distant early warning system now built in across our 14 hospitals. So although we're in Philadelphia, Pennsylvania, and New Jersey, certainly we're not as big as Banner, but I think have many of the same issues. So we already mentioned staff exhaustion. I think we're flexing the beds as appropriate. What is interesting, David, is even in one city, the number of cases seems to be inexplicably variable depending on which hospital, and that has a lot to do with very, very local factors at the zip code level: age, number of nursing homes, access to other types of care. All of that, I think, is reflected in the slide that you have here. The staffing, of course, is still a gigantic challenge. Like a lot of places, as Julie noted, we are rolling out the vaccine tomorrow, Wednesday. There's a press conference at this moment with our mayor talking about what's going to happen, so that's exciting. Politics plays a role. If you look at your third bullet, Philadelphia County, home of the city of Philadelphia, is totally separate from the other 66 counties in our state. The governor controls that. The Department of Health controls the vaccine disposition in our county. So only in America, Winston Churchill, one thing about Americans, they'll exhaust everything till they come up with the right answer, So it's a patchwork quilt of different approaches. I know we're going to get to that later. But the headline here, overall weekly hospitalization at its highest point, that is troubling. I would point out to all of our wonderful attendees, this is exactly what the experts predicted, right? All the way from Dr. Rick Bright to, of course, Dr. Fauci. I mean, we're exactly on schedule 2.5, 3 weeks post-Thanksgiving. What I think we really have to worry about, which we'll talk about later, is what will January look like 2 weeks after Christmas, as Julie alluded to.
Yeah, absolutely. History repeats itself. So going back to the Spanish flu epidemic of 1718, again, similar thing, Christmas, that second Christmas. So, Julie, what's the experience there today at Banner?
Yeah, so to play off what Dr. Nash just said, it's very, I would say from a capacity standpoint, we are at capacity at a number of our very large hospitals in the Arizona region and Colorado region. I think what's interesting this time is it came from the north downward. So the original surge we saw, kick off in Arizona, in Colorado. Colorado kind of got hit hard the first time, and then it moved to Arizona. This time, we saw our Nebraska and Wyoming facilities from a surge perspective get hit really hard way before, almost probably 6 to 8 weeks before we saw that same surge trend line in Arizona and Colorado. So it was kind of opposite of what we saw last time. We saw very few cases of COVID in the north and more so in the south. And with this second surge, it has concentrated in the north and then moved down south. So we have started to use all capable predictive modeling to determine what the end of December, January, and February are going to look like.
And hence your earlier statement about the importance of data. Excellent summary. So, David, we've talked about this vaccine. People have a lot of hope for it. Sometimes that hope is overseen, and we talked about the sort of Swiss cheese approach. What do you think the spring is going to look like?
Yeah, so I just saw the Warp Speed fellow on CNN before we got started talking live, and this has been his consistent message, and Dr. Fauci's too, that at least category 1, 1A, 1B, that they will all be vaccinated by the end of January, and then February and March into the second category. So look, we need additional vaccines. That's the Moderna is getting approval. J&J will be right behind. We need different technologies. I think we'll have that. And then we're going to need a lot of creative and powerful logistics. And from a population health perspective, we're going to need a major educational effort. And that could take all kinds of different forms. I would love to see, President Obama, President Bush get their shots on television, and President Biden as appropriate. That would be helpful, but actually it would be really great if LeBron James got his vaccine on television. And I think, quoting Harvey Feinberg, take the shot. Get it? Take the shot. And that's what we need. So I think if we get people who most Americans really look up to, like LeBron James, that'll go a long way to helping the folks who have doubts take the vaccine. I can share with you, we did a survey of our 35,000 people. We had 12,000 responses, and 75+% said they were strongly or largely in favor of taking the vaccine. But when we broke that down along racial lines, it is, I can't give you the exact number because it's not published, but far fewer of our employees of color said they would take the vaccine. So we have an important population health obligation as it relates to education about the efficacy and safety of all the vaccines.
Yeah, and I think to the point we've talked about before, using the James Reason model, the vaccine itself will not be alone effective in addressing this issue. Julie, how are you at Banner about the different ways to deal with this over the next 3 to 4 months?
Yeah, I think everybody is very excited about the vaccine in and of itself, but one of the things that we will continue to practice at Banner has been very important, and our Chief Medical Officer, Dr. Marjorie Bessel, has also, been part of lots of local TV shows and talking with the governor and the Wall Street Journal, saying that we still have to practice, our masking and washing our hands and doing all the things that we did before, because not everybody is getting this vaccine the first round. So, we don't want to let down our guard. We want to keep practicing all the things that we've been practicing because the virus is so new, and I think we're learning new things about it every day. And so one of the things we say at Banner is mask up. And, we want to do our part in the Arizona region and Colorado and Wyoming and Nebraska and California to show others that, Banner is dedicated to the safety of everyone and everyone around them. And so as we learn more about the vaccine and more people are able to receive the vaccine, we'll learn what precautions that, we can, relax on and what precautions we still need to keep in place until a majority of, like Dr. Nash was saying, the U.S. is actually vaccinated. So I think it'll be, 6 months of continued masking and hand washing and being socially distanced and making certain that we practice, all of the things that we've been doing for the last 6 to 8 months.
Yeah. It's a tough message, David Nace, and I know our listeners already internalize a lot of this. The James Reason model in this wonderful graphic, this is from 1997, and he's one of the sort of grandfathers of the high reliability movement and the Swiss cheese model generally attributed to him was first applied to aircraft safety and then to healthcare quality and safety, where we know that an error is 85% of the time system related because it literally threads the needle through the Swiss cheese. I think Julie's totally right, and it is going to be difficult because even after we get widespread vaccination, most especially in the workforce, healthcare workforce, we still have to do the masking, the social distancing, the hand washing, and all the rest. I think that's really, really important. However, I want to emphasize something that we haven't talked about, which is in this diagram, and that is fast and sensitive testing and tracing. I strongly urge our listeners to go online and read all the work of our colleague, Dr. Michael Mina, M-I-N-A, at Harvard School of Public Health. He's the man when it relates to testing. We have had a national failure. Absolute failure is the only word to describe it. Terrible failure as it relates to lack of immediate, no prescription necessary, high sensitivity, high specificity, inexpensive, antigen, right turnaround, immediate testing. No reason why we couldn't have done this back in May, June, July. While we're sitting here in December without this is just a terrible outcome. So the faster we could get the testing part of this to a wide dissemination, that will greatly aid the mask wearing, the social distancing, and so on.
Point well taken, and I love this model. Let's check in with our audience and see what are the integral parts of their COVID-19 strategy. So if everybody in the audience, if you could please go on and select one or more of the following that your current strategies are important in patient engagement and care strategies. So are you using virtual assessments to assess high-risk patients? Are you rethinking acute care planning capacity, which we'll hear from our audience about what they've done later on? Are you incorporating SDOH, social determinants of health assessments, into your strategy, or building a command center? So while we're doing that, Julie and David, I'd like to talk a little bit more about this Swiss cheese model. You know, it really, there's a lot of hope from the population that vaccine, now that it's available, will cure everything. And David, you've done a nice illustration of what we learned around safety and the importance. Over the next 6 months, what do you see as the major challenge? Let's start with you, Julie.
You know, I think one of the major challenges here is you know, kind of sheer capacity issues and transport issues and staffing issues for us. Where, you know, we're looking at the first surge. We did not max out at any of our facilities, nor did we max out on staffing. And this second surge has even though we've been kind of watching it, and like Dr. Nash said, it's absolutely what Dr. Fauci and some of the others have said. It has come, and it has come at more rapidly and with greater numbers of needed hospital beds as well as nursing staff. So over the next 6 months, you know, we have a plan in place to make certain that our hospitals that are at capacity are sort of, I'd say, tiered, if you will, so that if a hospital is reaching capacity, we now have a tiering strategy, as well as a strategy for a hospital where we percentages of COVID patients, at what point, you know, do we max out on percentages of COVID patients and transfer to hospitals that aren't as full, so that our patients get appropriate care. We also participate in the transfer line for the state of Arizona and Colorado, so we do receive a lot of transfers into our banner locations. So we have spent a tremendous amount of time and effort building out additional beds and double bedding where we can, and opening, you know, additional wings in our hospitals so that we can partner with our fellow hospitals here in the Arizona and Colorado area to take care of these patients as they come off the surge line.
Very thoughtful strategy and multimodal. Let's quickly bring up the results and then turn to you, David. I think the results probably are in. Here they are. David, wow. How does this fit multimodal as to your strategy at Jefferson?
Yeah, well, just taking a look at this. So, yeah, virtual assessments. Okay, that's great. So, looks like 2/3 or so of folks have some kind of online way of assessing both patients and employees. Rethinking acute care capacity. I think everybody's doing that. Interesting. Incorporating the social determinants of health assessments into care management. Well, yeah, about 1/3 of folks are on top of that. I think that's probably one of our biggest challenges, right? Because we have poverty driving the principal social determinant is poverty, most especially in Philadelphia. So if folks don't have enough to eat, they got to go to work, they got to take public transportation, they're in a multi-generational household, they don't have the luxury of work from home, they're at higher and higher risk all the time. And in our city, most of those folks are people of color. So incorporating the social determinants, that means getting the vaccine out into the community where these people are and giving them equal, if not higher priority. So I'm sort of surprised that only 1/3 of our attendees are thinking about that, but I understand it. And then building a data-driven command center, well, again, that's sort of like number one. I think most folks, 2/3 are on top of this. So I would say, David Nace, this looks just about right. I think the surprise for me is only 1/3 of folks, at least who are listening today, are incorporating directly the social determinant assessments. This is the real soft underbelly of our broken system. And if you don't have enough food in the refrigerator, you are going to go to work no matter what, even when you're sick. And so then you're going to spread it, and then you're going to fill the Banner beds and the Jefferson beds. So it all things come back to what are we doing at the ground level to tackle these social determinants?
Yeah, that makes a lot of sense. And I think your point about the data-driven command center is spot on as a piece that most of us have started to use initially. And Julie, you've mentioned data as the key. So let's talk a little bit about your experience, Julie, at Banner. Tell us a little bit about Banner Health, and then we'll get into it.
Yeah, so as you can see here on the screen, we have 30 hospitals, 400 urgent care and ambulatory locations, and about 1,100 employed physicians, and another 250 affiliated physician practices in our different states. So we care for about a little over 1.35 million members every year. So Banner not only has our hospitals, but we also have our own Banner Aetna health plan, and our Banner University Medical Center Hospital also has its own health plan. So, we care for about 45% of the population, at least here in Arizona. I think.
No, I was going to say, it's a great overview, multi-state, multi-environmental geographic areas. So I think it's a great case study of how you've approached this.
Hey, Julie, I'm going to jump in. Just go back to that slide for 1 second, David, if you could. Yeah. So 1,100 employed physicians. That's fascinating. That's a low number given your size. That's the size of the Jefferson University Physicians Practice Plan. So I take it then that most of your doctors are not employees. Do I have that right?
It's about, I would say it's about half and half as we've acquired other systems and as we've done joint ventures with physician practices, orthopedic practices, MD Anderson, for instance, for oncology. We do a lot of affiliation work through our insurance plans as well as our Banner Health Network. So yeah, we have a kind of a mix of both employed and non-employed physicians.
Great, thank you.
Julie, walk us through the response over the past year.
Yeah, so like most people, we immediately realized that we didn't have all the information that we needed. We started out with a few kind of dashboards that covered everything, and now for surge number 2, we have 22 dashboards that are our operational command center. So I liked people saying that they were building out their operational command centers from a data perspective. And so I would say to you that we learned a lot from the previous surge, and what we've done in between is we've really focused on our lessons learned. What did we really need to know? And so using the Innovaccer platform, we built a bed modeling tool that it's predictive in that now we are able to predict 4 to 6 months out. We have that attached in the back into our finance systems as well as our staffing systems. And so the predictive analytics and capabilities have allowed us to plan 6 to 8 to almost 10 weeks out. And so when we do our staffing now, we feel more comfortable about the staffing needs. And as as the COVID and the flu and some of the other things that are happening during the surge change, we are able now to update our predictive model to fit with the scenarios. And we've been about 95% overall with the predictive analytics. And so what we've learned is we've taken in all kinds of data. Dr. Nash keeps referring to all kinds of different data, but we're looking at all different kinds of data sources, not just here in Arizona, but across the country, and taking advantage of Johns Hopkins and everybody I think watches the U.S. Dashboard. But I think this time I would say we were more prepared. We saw the surge coming early, and we started staffing and acquiring beds and vents and supplies to make sure that we had supplies to fit the scenarios coming at the end of December and the first 3 months of 2021.
Yeah, it's an interesting question from the audience. You've made a lot of data, dashboard, operational changes, capacity planning, predictive modeling. How much of this do you think will serve, and this is a question from the audience, will be permanent? Meaning, how much of this will be learnings that will carry forward after this crisis?
I think, what we're seeing is all of this it gave us a very clear insight to the fact that we did not have an aggregation point for all of our data. We had lots of data in very disparate areas and lines of business within Banner, but we didn't have one kind of operational view into what was going on system-wide. So I can tell you that this has taught us how important it is to make sure that, first of all, we know where all the data sources are, that the data sources are connected, and that anything that is manual today, figure out a way to get a vendor or get a process in there that you can automate the data or automate the collection of that data. We've been operating, until you hit a pandemic, you operate kind of like you do every day. You don't make huge changes. And so I can tell you we've made a 180 in the last 8 months on data collection and planning to put things up in the cloud so that we can share data not only with Banner, but our other hospital facilities within the different states we operate in.
Yeah, and we've seen this with other folks where this issue of managing the crisis with data becomes important, and moving to the cloud is very helpful.
Yes.
David, I think that's been your experience too at Jefferson, is that right?
Yes. I mean, again, Banner is remarkable just in their size and scope. I think everybody could take a lesson, from the pages of how Banner did it. It's a really pretty remarkable dashboard that they've created here. I think most big places have something almost, like this, but given their size and scope, it's pretty amazing. And obviously covering a much wider geographic area, is really, really important. So again, we've covered some of this. I think the pre-procedural testing, really great. We had to make that a priority and stop doing voluntary testing in the community. Again, going back to my previous point, crazy that we're at this level having to allocate precious testing resources when everybody should be tested all the time. Only in America does the National Basketball Association and the NFL and college sports gets priority over citizens in major cities and citizens of color. I mean, this makes no sense to me at all.
And Julie, the size and scope and diversity of your populations, I think this rapid data visualization really helped. And clearly with this pandemic surge, you've had to do a lot of forecasting. Walk us through sort of what we're looking at here.
Yeah, so we in Arizona, this dashboard is depictive of Arizona mandates from our governor. So this dashboard allows everybody in the Arizona region to see our total bed capacity, our expanded capacity with the surge, and also it shows with the governor's mandates. If you see the horizontal lines here on the screen, you can see that each of the colors of the lines represents the governor's mandate and our ability to operate within the guidelines set out by our governor. So and you just mentioned elective surgeries. So for us, elective surgeries, anytime the daily percent of occupied beds goes above 80% across all of our hospitals, and as you can see, this is our Arizona region, all hospitals, it is the governor's mandate that we must cease elective surgeries. So we keep a very, very close eye on that. And then we've also been able to incorporate this type of dashboard and horizontal capacity lining for our different states. The other thing we did is we added flu capacity to this. So as you can see, the colors represent the different areas of forecasting that we're taking into account. We have loaded 3.5 years of data onto the Innovaccer platform. So now we are able to do forecasted, best and worst for each of the different drop downs there. So elective surgeries, COVID, flu, by region, by facility. So this dashboard is used throughout all of our facilities and helps us monitor and manage not only capacity, but staying within the regulations and the limits of each of the different states for capacity levels and treatment of patients.
Yeah, I know your dashboards have been very helpful, and you've set up a number of them. While you walk us through this, there is a question from the audience about how is supply chain operations tied to clinical operation predictive analytics? How do you pool supply and clinical need together? So maybe you can speak to that in regard to what we're looking at here.
Yeah, absolutely. I don't know if we have a depiction of this here, but we do have, if you look at the bottom here where we have medication consumption and medication predicted medication consumption, we have dashboards that represent not only our laboratory supplies, but our vent supplies, our PPE supplies, all our mask supplies, as well as our medicine supplies. So we have daily intake to these dashboards. We call this our Skittles dashboard. One of our doctors so kindly named this the Skittles dashboard, but the Skittles dashboard is the landing page every morning. It gives our in-house census across all of our regions. It gives our positive and negative precautions, both vented and non-vented. It also gives us, a good picture of intubations and extubations and how we're doing. And then not shown on this graph is, if you click on each of the boxes, we have a graphical representation of each of the different Skittles boxes here, and you can see one against the other. So if you want to see the number of enhanced precautions versus the negative enhanced precautions, it gives you a view into some of that. So, we're really proud of this, and this does incorporate our finance system, our supply chain system, our capacity management system, our transfer services system. So there's a bunch of data that comes into this daily, and it keeps us apprised of kind of how we're doing overall operationally.
Yeah, and we've been really proud to work with you in helping to stand this up through your operation. And this is a great example of how you've been able to use that information.
Yeah, so it's interesting. We kind of only figured this out as we went along. Started loading data in Innovaccer in the month of March, in April timeframe, early in the surge. And what we realize now on this dashboard is it created the two categories here are our PUI rate, so our persons under investigation, and then how many of those patients actually turn into COVID positive. So what we realized over time, now that we have almost 10 months of data, is that every time the orange line crosses the pink line, we're going to start to have our surge. So as we've been watching this, and as we've watched the orange line start to climb, we know at Banner that the persons under investigation rate is going to go up. The number of people that test positive is going to go up, and then the number of people, the orange line, in our hospitals, our capacity is going to increase exponentially based on the crossing of the pink and orange lines.
Well, really super work, and I think even as a system, an operation system managing this data, it's also critical to outreach to the patient.
Absolutely, absolutely. And then I think we were lucky enough we have a phenomenal digital front door team. And because we do have a health plan as well, we do have probably a little broader reach, because we have tools and capabilities, like you're saying, to reach out to our patient populations, and have tools on our cell phones as well as on our website to start scheduling those appointments. And we added, I think Dr. Nash alluded to, but we added the telehealth visit capabilities and the ability to do appointments at our fairgrounds and some of our tent locations around our different states in Colorado and Arizona, to accommodate, depending on how comfortable you feel and if you want to interact with anybody, been able to accommodate those patients based on need and urgency of care.
Yeah, it's great. And one of the questions that came in from the audience was, who are the primary users of all these different dashboards and systems? Sounds like a multitude of people.
Yeah, so it's interesting. We kind of brought it together initially for our executive staff, but what we learned is our house supervisors, our quality folks, all of our CMOs, our chief nursing officers, and our CMOs at each of our hospitals uses this trending, as well as infection control. So infection control can see the dashboards, and we also have lab and pharmacy here. So we have, a little over 1,200 people that have access to this data every day. And then there are individual dashboards that we allow people to have access to depending on their role within Banner. So we've worked very hard with Innovaccer to put in different groups and role-based security. And I think one of the positives for us is it's integrated with our Teams sites. We have a big Microsoft Teams site. So our Active Directory and our single sign-on capabilities working with Innovaccer has allowed us to distribute this much more quickly and in a format that people work in every day. So it's not a huge change for them.
Right. Well, David, I'd love to have your comments on what you just heard, and then talk a little bit. We'll get into the Jefferson.
Yeah, so I'm listening carefully to Julie, and I'm getting greener with envy as she's talking. It's pretty incredible. But I think, beyond the technology that Julie described, which is formidable, and the role unquestionably that Innovaccer played to create the scaffold, I think two things emerged for me, David Nace: transparency and accountability, right? So all of this data created unbelievable transparency across the Banner, and that creates accountability because everybody could see what he or she's responsible for. Whoa! So imagine, let's hope that we could take a little bit of this and a little bit of that, and that would be one of the enduring positive silver lining take-home messages, come summer 21, of transparency and accountability for everything we do. Wouldn't that be spectacular? Instead of
and David, I remember you and I first met in Arizona at your first class of teaching quality many years ago, and you were talking about transparency at that point too. So
I think I'm probably the longest broken record that most people can think about as it relates to Jim Reason, the Swiss cheese, transparency and accountability. Well, because that's what I hear when I see a dashboard, I see incident command, I see updated practice guidelines. I mean, it's quite remarkable. And I'm so hopeful, almost to the point of prayer, that these types of concepts will endure once we're out of the terrible tunnel. And when we come back in the summer, God willing, of 21, we'll see if this transparency and accountability still exists. I sure hope so, because that's the only way we're really going to dig out of this hole. Yeah. So this is a great graphic, and again, I have to give credit to the real clinical leaders, Bruce Meyer, John Gleason, the entire team, all the chief medical officers, our 1,100 plus faculty practice plan, all our affiliated doctors. I mean, these doctors, nurses, and pharmacists who are on the front lines, it's just incredible. And it's largely a young person's game, thank goodness, as it ought to be. And at a place that has a GME program, one of the largest in the country. So we can't forget about all the young doctors of every size, shape, and color who are at the front lines doing this every day. So this is Jefferson Health, due largely to our amazing enterprise CEO, Steve Klasko. So we're now at 14 plus hospitals, 35,000 employees. We're one of the largest employers. And remember, Philadelphia, unlike Arizona, just Philadelphia, we got 5 medical schools, right? So if you took Sidney Kimmel Medical College, Jefferson Medical School, and Drexel University, that's one city, 2 of the largest private medical schools, we're training 5% of all doctors in America at this moment. So it's medical care and medical education is our core business of the nation's number 10 city by population. It's amazing. So it's a big operation.
And you've had a big response, I think, given your experience with COVID and adapting some strategies. So tell us a little bit about what's been helpful. Innovation.
So here, I hope folks who are listening will go and look at the work of my incredible colleague Judd Hollander and his team. I mean, we have very senior physician digital health leaders who have enterprise level role, and we were promoting telehealth nearly almost 5 years ago. So these amazing leaders were able to quickly ramp up our telehealth presence. I prefer to call the whole thing digital health, as you've alluded to here, because I think this is where we're going. And Dr. Klasko, our enterprise leader, talks about Jefferson everywhere. So where's Jefferson? It's on my cell phone, it's downtown, it's in the neighborhood, it's in urgent care. Kind of similar thinking to what Banner is obviously created, but electronically and digitally, Jefferson is everywhere. That's the method behind the madness. And I think this is a good graphic to describe that. So we were well prepared, David. I wish I could take credit, but I can't. It's Judd Hollander, his amazing team, and Bon Ku and others who helped create the technology, disseminate it, get it to all the right people. However, let's also recognize that for a lot of our service area, if you don't have a cell phone, if you're not connected to the internet, you can't do digital health. So that's a population health challenge again. And so, as many Zoom accounts as you have, that's wonderful. But if you're poor and you don't have an internet connection, none of this makes any sense. And that is going to be another enduring lesson when we come out of the terrible tunnel.
Absolutely. Well, let's check in again with our audience and see what they're doing in terms of their top technology-enabled poll for 2021. So again, let's bring up the poll and have each of you talk about, just go ahead and select one of the following, not all, but select one of the following. What are you currently seeing as your top goal using technology to manage the pandemic and think about a new way to digitalize your healthcare system? So while we have the audience checking in on that, we have a lot of questions coming in. Certainly, Julie, there was a question, great dashboards. Are these generated using Power BI? I think it's a little bit more sophisticated, so maybe you can take that one.
Yeah, so actually, interestingly enough, they are generated using Power BI and then the capabilities behind the Innovaccer platform. So what we actually use Innovaccer for is a data aggregator. So they are able to aggregate tons and tons of data. We landed a bunch of data raw. Obviously, we have 84 different interfaces into Innovaccer today, and I can tell you when we started kind of in the March, April timeframe, we had none. So we were able to quickly interface a bunch of our disparate systems. So we have our HR systems, our finance systems, our pharmacy systems, our insurance claims systems, all rolling into Innovaccer now. And so I think one of the things that we learned from COVID is everybody was asking for COVID data. So depending on what your role was and what you do within our facilities, the type of data and the visualization of that data is different. So we built a number of different dashboards, including very specific dashboards. So we have lab turnaround time dashboards for testing, and we have in-home dashboards that we've sent patients home from our hospitals with wearable technology, and we're monitoring that technology. So our dashboards collect the data that is coming in from our 3 top telehealth vendors and our wearable device vendors. And so we're learning that if you have one place with that aggregated data, then the visualization piece is much easier. And the Power BI technology is kind of a rapid deployment, gives us a rapid deployment capability, and also gives us easy connectivity. A lot of people have, the Microsoft products. And so Innovaccer has allowed us to use both of the technologies. We have AWS and Azure technologies here at Banner. So Innovaccer allows us to bring in the technologies we have here today and work with us to not have to spend extra dollars to get the data and the visualizations up quickly.
And that makes a lot of sense. Well, let's go ahead and check in with our audience and see how they selected their top technology goal for next year. Results should be coming up now. Wow, that's a little bit more spread out, David, isn't it?
Yeah, but wow, really interesting. I think I would have guessed that expand telehealth would be at the top of the list, almost double. Yeah. So, and then automate care pathway and care coordination. Okay, so I see 2 things here, David, and they're sort of maybe in my worldview in opposite directions. Let me explain what I mean. So expand telehealth, well, obviously really important. Preserve revenue, preserve connectivity. That's sort of a must-have at this point, given the way we're paid. But very excited to see that automate care pathways and care coordination. That's a positive. I hope that'll be an enduring quality and characteristic by summer of 21. So to some extent, it's a little piece of preserve the old, get the revenue and keep the revenue by expanding telehealth and connectivity. I'm not deprecating it, but obviously really important to the revenue stream. And on the other hand, pretty exciting, automate care pathways and care coordination. So very interesting results.
Yeah, I agree. Very interesting. And I think to your point, the 2020 experience really can help move us along from what we've talked about, from evolution to revolution, to really experiencing the change we've talked about for many years. So we are potentially moving to a new normal where virtual care networks finally gain acceptance. Julie, is that your perspective?
Oh, definitely. I think we are all seeing that the high touch comment here is I think what everybody's experiencing. Telehealth is allowing us to do high touch, but in a safe environment. We can see visually our patients, how they're doing, and we've had a tremendous uptick, almost 47% in telehealth visits. And we feel like that this is going to be kind of the new norm. I mean, when people can interact with a physician or a patient caregiver from their home or from a home care facility. We are realizing that the technology is not just for young folks anymore, that it's kind of expanding, to our older populations as well. So I think actually, this new normal is going to be more telehealth and more virtual.
And to David's point about social determinants of health in different communities of different population sets, there's a question from the audience, David. Has the panel experienced much use of these technologies for physical therapy, occupational therapy, pain, stress, behavioral health, and others? So,
great, yeah, great question. The short answer is a tiny bit, and we hope there'll be more of it. I think that's, but once again, so I have to be the pop health guy here. That will only work if we get paid to achieve health. If we get paid to do piecework, none of that will work, right? So let's all get very real here for a moment. While telehealth, digital health, we love it. Who wouldn't? It's cool. I get it. But if you get paid to do piecework, that's exactly what we'll do. If you get paid to improve health, go upstream and shut the faucet instead of mopping up the floor every day. Well then physical therapy, nutrition, exercise, counseling, all of a sudden all of that will be paid for, and appropriately so, because that will drive health, not health care. And David Nace, you and I have been around a long time. It's so great that we have Julie nestled between us, these two old guys here. But look, let's not kid ourselves. If we just go back to how it was, anybody who believes, raise your hand if you think the system that brought us to the edge of the abyss is the system we need to take us forward. Raise your hand. I don't know what you're smoking or drinking, but it cannot be.
Yeah, and what I really like is this concept of the patient experience, what we call the fourth quadrant.
Exactly. And again, patients who don't have access, don't have health insurance, can't put food on the table, have to go to work no matter what. This is unfortunately a big part of what our country is all about at the moment.
So Julie, how would you summarize for the audience? We've had about 350, 400 people on the line across the country. How would you summarize the lessons that we've learned for other health systems in your experience of that?
I think I would say that I think we learned very quickly that our caregivers and our frontline workers and our staff, and it takes everybody moving to this new paradigm of data, and so Dr. Nash mentions the folks at these different systems, and so our CMOs and our chief nursing officers and our COOs and our operations staff and our very large nursing and hospitalists and physician staffing and our RTs, and physical therapy folks, they all were committed to making sure that the data we have on these dashboards and the data that we're collecting is both operational as well as they can take action on it. So, they were very clear about, we don't need this data. This is the data we need to come in and see every day that makes us be able to take care of our patients. And so I think what we learned is the data is just the data unless you have the buy-in of the folks that are going to use the data, and that the data is actionable every day and helps them do their job and care for our patients better. So it was a learning process throughout, and it takes a village. It took everybody and everybody's feedback. We worked directly with a bunch of physicians, ED as well as hospitalists and the nursing staff, and so I would say to you that the learnings from Banner are it's collaborative. It's almost like a living document. It's collaborative. It's interactive. We take feedback. We make adjustments. And as the search has gone on, obviously we've learned a lot more. So be willing and be flexible to keep updating these dashboards, and we feel like that these will live on and will We've even kind of taken a look at Banner, across Banner, and said, hey, what are kind of the top things you would want to see? So we have a top 100 dashboard going forward from this pandemic. Now we have the data, now we have the platform, we have the capability. Like Dr. Nash was saying, what else can we do with it? What else can we do for our patients, and what else can we do for our healthcare workers, so that we're having a vision and a visual into every day within Banner.
That's a great summary. And I appreciate all the work that we've done with you. Just for the audience to summarize, and David, I know you've often applauded the way we get this on one slide, but it really is about pulling the data in from all these different sources, multiple EMRs, health plan data, paid claims, bill claims, pharmacy data, and then data from the community, because that is critical, I think, to addressing this SDOH data, and then unifying it and activating that with contemporary technology to the cloud, to all the different participants, the doctor, the care coordinator, and automating functions as much as possible. And the name of the company that we come from, Innovaccer, was all about how do you accelerate innovation accelerator. And I think, David, you've often this resonates with sort of the way you see the future as well.
Yeah, and we've covered, this is just a great one-page graphic of everything Julie described. I mean, Banner's awfully lucky to have you, Julie, that's for sure. And I think what you've done is pretty remarkable, using the scaffolding and the platform. And when you look at the dashboard, it covers a good part of what's in this diagram. So it's sort of like bringing this diagram to life, is what I heard so carefully described by you. It's really pretty remarkable. And I think, again, let's hope all of this is enduring positive change post-pandemic. Wouldn't that be wonderful? And striving to go upstream to improve health rather than just, test and procedures and all the rest.
Julie, there is a question from the audience, just to summarize before we close. How do you think about this with the use of the technology, the cloud, all this information, connecting with the patient with the smartphone? How do you think about it from a HIPAA and privacy and security perspective?
Yeah, so I'm glad you asked that. We have a tremendous security team here at Banner. And so every contract we sign, all of the things that come into Banner, our security team vets it. We have a very strict standard for sharing and caring for the PHI and the patient information that we have here. Not one system at Banner is put into place, or one interface or one connection made until our security and our architecture. We have a very large architecture review board here, very formalized review board, represents lines of business here in Banner, reviews to make certain that we are taking safeguards for all data, and that data, if data can be wiped remotely, data can be brought back remotely. We are very I would say selective in our partners, and those partners have to have proven scalable, secure environments. And then we do audits and checking of those environments. We install our own audit tools and our security tools on the Innovaccer platform, and they allow us to audit their platform for connectivity and some other things. So we're very, I would say, protective and aware that sharing brings a bit of kind of risk, but that risk is part of what we have in our healthcare industry here today. And so we manage that risk by making sure that our security is the best that can be out there, as well as our employees that do these roles here at Banner.
This is great, and I really want to thank both of you for participating. And just in closure, what I'd like for each of you to do, we've had an outpouring of questions just in the last 3 minutes.
Okay.
If each of you could actually just comment on, this issue of transparency, accountability, and collaboration. Can each just summarize from your point of view, David, what are you doing at Jefferson to champion a culture of transparency, accountability, and collaboration for the audience?
Yeah, great. So very quickly, so it's been my amazing privilege to be the founding dean of the nation's first College of Population Health. So our textbook is now in 80 such schools and programs around the country. Our journal, Population Health Management, our annual meeting, the Population Health Colloquium. So David, you and I have talked about this. It's been an amazing 10-month journey during the pandemic when folks are coming to our door saying, you know, that population health stuff sounds pretty important now. So I'm sorry it took a pandemic, but it is very personally gratifying to see an interest in these issues. And I can summarize everything we're about: go upstream and shut that faucet instead of mopping up the floor every day. That's the key.
Yeah.
And thanks, David. Julie?
Yeah, I'm excited, you know, and I probably will be sending some folks your way for the population health piece, because I think it has really changed the look and the face of data, as well as the collaboration between the physicians, the physician leaders, as well as our insurance companies. And so I'm excited to see, you know, what the future holds for us.
Sounds like a collaborative closing moment. So thank you both very much. And thank you to our audience for participating. And with this, and a great thank you again, and a happy new year, hopefully.
Thank you.
And
Bye-bye.
look forward.
Bye-bye. Thank you.
Thank you.
Bye-bye.